Good afternoon, ladies and gentlemen. My name is Dr. Carrie Mulwitz. I'm the Geriatric Psychiatry Fellow at the Department of Psychiatry here at the University of Iowa. And I will be presenting today on dementia in the context of serious mental illness. I have no disclosures to make. I would like to start by presenting you with the overview of the topics at hand today. We will start with a presentation of a case example. Next, we'll look at some specific statistics regarding dementia and define dementia and a neurocognitive disorder. Next, we'll take a look at risk factors, screening tests, and different treatment options available for dementia. Next, we'll switch the focus to mental illness statistics and define serious mental illness. And finally, we'll discuss dementia and serious mental illness, looking specifically at dementia and depression, dementia and bipolar disorder, dementia and schizophrenia, and we'll look at the different types of dementias that may have psychiatric presentations or features. And finally, we'll briefly talk about intellectual disability and dementia and Down syndrome and dementia. While there has been considerable and welcome attention in the area of dementia over recent years, the mental health of people in later life, and specifically the complex relationship between dementia and mental health problems, is a neglected area in public discourse, policy, and service provision. During this presentation, we will take a specific look at dementia, including prevalence, risk factors, screening tools, treatment options, and public impact. We will also look at mental illness prevalence and specifics regarding common mental health conditions. The correlation of dementia and Down syndrome and dementia in the context of intellectual disability will be briefly explored. We will focus largely on dementia in the context of serious mental illness by discussing the similarities and differences between dementia and serious mental health illnesses. Here are the objectives for today: defining dementia and neurocognitive disorders, describing risk factors, screening tests, and treatment options for dementia, discussing dementia and serious mental illness such as depression, bipolar disorder, and schizophrenia, and examining types of dementia with psychiatric presentations or features. I would like to start out with a case example. A successful 56-year-old grocery store owner began to have trouble finding names for people and objects, such as types of produce. He continued to place newspaper ads for his grocery store deals, but had trouble filling out paper orders for food shipments, making frequent spelling errors. Shockingly, he was caught stealing a wine bottle opener from the liquor section of the store. Not long after, he began to search his backyard, spending many hours looking for pine cones. While at home, he began to play solitaire on his computer compulsively for 6 hours every day. He developed a new interest in tennis, and his game steadily improved. He stopped working as a grocery store owner, but obtained a grocery delivery job and learned and remembered a complex route for delivering packages. There was no family history of dementia. Let's talk about dementia statistics. An estimated 5.4 million Americans of all ages have Alzheimer's disease in 2016. 1 in 9 people age 65 and older have Alzheimer's disease. It is estimated by the year 2015, the number of people age 65 and older with Alzheimer's disease may nearly triple to a projected 13.8 million, barring the development of any medical breakthroughs to prevent or cure this disease. Alzheimer's is officially listed as the 6th leading cause of death in the United States, and it is the 5th leading cause of death for people age 65 and older. It is estimated that approximately 10 years after the onset or initial diagnosis of Alzheimer's dementia, you can expect death. In 2016, the total payments for health care, long-term care, and hospice are estimated to be $236 billion for people with Alzheimer's and other dementias, with just under half of the cost borne by Medicare. Next, I would like to specifically define dementia in a neurocognitive disorder. In 2013, we started to use the DSM-5 criteria in order to diagnose what is now known as a major neurocognitive disorder. Previously, this was known as dementia in the earlier version of the DSM booklet. So I wanted to go through the specific criteria so you can see the change from the dementia diagnosis to now the major neurocognitive disorder diagnosis. So for dementia, there had to be a memory impairment. There also had to be at least one of the following: aphasia, apraxia, agnosia, or a disturbance in executive functioning. The cognitive deficits each cause significant impairment in social or occupational functioning and represent a significant decline from a previous level of functioning. Also, the cognitive deficits do not occur exclusively during the course of delirium. This was the definition for dementia to diagnose this. It changed a little bit and is a little bit more specific for the neurocognitive disorder. There has to be evidence of significant cognitive decline from a previous level of performance or in one or more of the following cognitive domains: learning and memory, language, executive function, complex attention, perceptual motor, or social cognition. Again, the cognitive deficits interfere with independence in everyday activities. At a minimum, assistance should be required with complex instrumental activities of daily living, such as paying bills or managing medications. Again, these deficits do not occur exclusively in the context of delirium. And furthermore, the cognitive deficits are not better explained by another mental disorder, such as a major depressive disorder or schizophrenia. In comparing now a major neurocognitive disorder to a minor neurocognitive disorder, there are a couple of fine details that differentiate the two. In a major neurocognitive disorder, there is evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. Compare that to a minor neurocognitive disorder, there is evidence of modest cognitive decline from that previous level of performance. In a major neurocognitive disorder, the concern of the individual, a knowledgeable informant, or of the clinician, there is a significant decline in cognitive function. And again, with a minor neurocognitive disorder, that decline is mild. In the major neurocognitive disorder, there is a substantial impairment in cognitive performance, whereas in a minor neurocognitive disorder, that impairment in cognitive performance may be described as modest. In major neurocognitive disorder, the cognitive deficits interfere with independence in everyday activities, and this is not necessarily true in a minor neurocognitive disorder. Next, I'd like to focus on dementia versus age-related memory problems. According to national research, individuals with age-related memory problems forget parts of experiences. They can often remember parts of the experiences later, and they can usually follow directions and care for themselves. Whereas individuals with dementia forget the whole experience. They rarely remember it later, and they are eventually unable to follow directions or care for themselves. There are many different types of neurocognitive disorders. This may include Alzheimer's, vascular, Lewy body, frontotemporal, hydrocephalus, traumatic brain injuries, substance or medication-induced, prion or transmittable disease, Parkinson's, and Huntington's disease, as well as multiple etiologies. Here is a pictorial representation of the different types of neurocognitive disorders. Next, I'd like to focus on risk factors for cognitive impairment. Increasing age is the strongest known risk factor for cognitive impairment. Other reported risk factors for cognitive impairment include cardiovascular risk factors, such as diabetes, tobacco, hypercholesterolemia, and hypertension. And these may be specific risk factors that we can see leading up to a vascular dementia or a vascular neurocognitive disorder, for example. Other risk factors may include head trauma, learning disabilities, depression, alcohol abuse or other substance abuse, physical frailty, and low education level, low social support, and never having been married. Again, here's a pictorial representation of the different risk factors that may lead towards a cognitive impairment. Next, I would like to focus on the screening tests for neurocognitive disorders. Screening tests for cognitive impairment in the clinical setting generally include asking patients to perform a series of tasks that assess one or more cognitive domains. These domains include memory, attention, language, visuospatial, and executive functioning. To date, the most widely studied instrument is the Mini Mental State Examination. Other common used instruments include the MoCA, or the Montreal Cognitive Assessment, the Clock Draw Test, the Mini-Cog, Memory Impairment Screen, Abbreviated Mental Test, Short Portable Mental Status Questionnaire, the 7-Minute Screen, and the Informant Questionnaire on Cognitive Decline in the Elderly. Of note, the United States Preventative Services Task Force concludes that the current evidence is insufficient to assess the balance of benefits and harms of screening for cognitive impairment. Here is an example of the Montreal Cognitive Assessment. If you're able to see, it tests the visual, spatial, and executive functioning, also naming, memory, attention, language, abstraction, delayed recall, and orientation. Here is a picture of the Mini Mental State Examination. And this again tests different cognitive domains such as orientation, concentration, recall, etc. Here is the Mini Cognitive Assessment, in which you would ask a patient to repeat 3 unrelated words, then ask them to draw a clock, and then recall the words. And below you can see the potential scoring that you could use to assess that mini-cog. I'd like to briefly touch on the treatment options for cognitive impairment. Pharmacological treatments approved by the U.S. Food and Drug Administration include acetylcholinesterase inhibitors and memantine. There are also several non-pharmacological interventions one may take, including cognitive training, lifestyle behavioral interventions, exercise, educational interventions, and multidisciplinary care interventions. Some of these interventions focus on the caregiver and aim to improve caregiver morbidity and delay institutionalization of persons with dementia. Next, I would like to turn the focus over to mental illness statistics. Approximately 1 in 5 adults in the United States, 43.8 million, or about 18.5%, experiences mental illness in a given year. About 1% of adults in the U.S. live with schizophrenia, and about 2.6% of adults in the U.S. live with bipolar disorder. 6.9% of adults in the U.S., or around 60 million, had at least one major depressive episode in the past year. Around 18% of adults in the U.S. experienced an anxiety disorder, such as post-traumatic stress disorder, obsessive-compulsive disorder, or a specific phobia. Among the 20 million adults in the U.S. who experienced a substance use disorder, over 50% of them had a co-occurring mental illness. Among adults with a serious mental illness, over 60% received mental health services in the past year. Next, I would like to define serious mental illness, and we will be specifically looking at bipolar disorder, major depressive disorder, and schizophrenia. Severe mental illness is often defined by its length of duration and the disability it produces. Illnesses include thought disorders, illnesses with psychotic symptoms, such as schizophrenia or schizoaffective disorder, and severe mood disorders or affective disorders, such as major depression or bipolar disorder. Schizophrenia and bipolar disorder are often thought to be 2 of the most disabling psychiatric conditions. They are most frequently associated with serious mental illness and most frequently cause institutionalization among persons with mental illness. I'd like to look into some specific details regarding bipolar disorder and its diagnosis. In order to diagnose bipolar I disorder, it is necessary to meet the following criteria for a manic episode. And again, according to the DSM-5, and this is effective as of August 2015, you need only to have a manic episode in order to diagnose the bipolar disorder. Criterion A, A distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased goal-directed activity or energy, lasting at least 1 week and present most of the day, nearly every day, or it could be any duration if hospitalization is required. For criterion B, during the period of mood disturbance and increased energy or activity, 3 or more of the following, or 4 if the mood is only irritable, are present to a significant degree and represent a noticeable change from usual behavior. So one may see an inflated self-esteem or grandiosity, a decreased need for sleep, for example, feeling well rested after only a few hours of sleep, more talkative than usual, or pressure to keep talking, or talking so fast that the words may even become slurred. Flight of ideas or subjective experience that thoughts are racing. Distractibility, as either reported or observed. An increase in goal-directed activity that could either be socially, at work, school, or sexually, or psychomotor agitation. For example, purposeless, non-goal-directed activity. Or excessive involvement in activities that have a high potential for painful consequences, such as engaging in unrestrained buying sprees, sexual indiscretions, or foolish business investments. This mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning, or to necessitate hospitalization to prevent harm to self or others, or there are psychotic features. This episode will not be attributable to the physiological effects of a substance, for example, drug of abuse, medication, or other treatment, or to another medical condition. I also want to further define a hypomanic episode, which you will see is similar to a manic episode, but there are some differences. In a hypomanic episode, there is a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy, and this will last at least 4 consecutive days and present most of the day, nearly every day. During the period of mood disturbance and increased energy and activity, 3 or more of the following symptoms, again, 4 if the mood is only irritable, have persisted, and they represent a noticeable change from usual behavior and have been present to a significant degree. And again, we see the inflated self-esteem, decreased need for sleep, etc. Another difference to point out between a hypomanic episode and a manic episode is that in the hypomanic episode, there is an unequivocal change in functioning that is uncharacteristic of the individual when not symptomatic. Moving on to a major depressive episode, which may be a component of the bipolar disorder. Also, major depressive episode may be seen in and of itself. In order to diagnose the major depressive episode, there will be 5 or more of the following symptoms having been present during the same 2-week period and represent a change from previous functioning. Also, at least one of the symptoms is either a depressed mood or a loss of interest or pleasure, and we term this as anhedonia. One might see depressed mood most of the day, markedly diminished interest or pleasure in all or almost all activities, significant weight loss when not dieting, or weight gain or decrease or increase in appetite, insomnia or hypersomnia, psychomotor agitation or retardation, and this is often observed by others, fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, and this may even be delusional, a diminished ability to think or concentrate, or indecisiveness, and recurrent thoughts of death, not just a fear of dying, and possibly recurrent suicidal ideations, perhaps without a specific plan, or a suicide attempt, or a specific plan for committing suicide. These symptoms will cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The episode is not attributable to the physiological effects of a substance or other medical condition. Next, I would like to look at the diagnostic criteria for schizophrenia. For criterion A, 2 or more of the following, each present for a significant portion of the time during a 1-month period, or less if successfully treated. At least one of these must be a delusion, hallucination, or disorganized speech, and that can include frequent derailment or incoherence. There may also be grossly disorganized or catatonic behavior or negative symptoms, such as diminished emotional expression. For a significant portion of the time since the onset of the disturbance, the level of functioning in one or more major areas, again, such as work, school, self-care, will be markedly below the level achieved prior to the onset. There will be continuous signs of the disturbance persistent for at least 6 months. This 6-month period must include at least 1 month of symptoms, or again, less if successfully treated, that meet criterion A, and these are known as the active phase symptoms. During these prodromal or residual periods, the signs of the disturbance may be manifested only by negative symptoms or by 2 or more symptoms listed in criterion A, present in the attenuated form. For example, odd beliefs, unusual perceptual experiences, etc. Schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out. The disturbance is not attributable to the physiological effects of a substance, such as a drug of abuse or a medication or another medical condition. Also, if there is a history of autism spectrum disorder or a communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to the other required symptoms of schizophrenia, are also present for at least 1 month, again, or less if successfully treated. Next, I would like to focus on the different screening tests in serious mental illness. There are several different screening tests available in depression. A very common one is the Patient Health Questionnaire 9, or the PHQ-9. This is a 9-item self-administered diagnostic screening and severity tool based on current diagnostic criteria for major depression, as we previously looked at. There is also the Beck Depression Inventory, which is a 21-question multiple-choice self-report that measures the severity of depression symptoms and feelings. There is the Zung Self-Rating Depression Scale, which is a short survey that measures the level of depression, ranging from normal to severely depressed. We have the Center for Epidemiological Studies Depression Scale, or the CESD, which is an instrument that allows patients to evaluate their feelings, behavior, and outlook from the previous week. Finally, there is the Hamilton Rating Scale for Depression, also known as the HAM-D, which is a multiple-choice questionnaire that doctors may use to rate the severity of a patient's depression. And here are a few visual examples of the different screening tests that we have for depression. First here we have the PHQ-9, and again too, this is based on the diagnostic criteria for major depressive disorder according to the DSM-5. Next, here's an example of the Beck's Depression Inventory. And again, this is a 21-question multiple-choice questionnaire that can be used to assess the severity of depression. Here's an example of the Hamilton Depression Rating Scale, or the HAM-D. Next, I'd like to briefly talk about a couple of different screening tests in anxiety. A very common one is the GAD-7, or the Generalized Anxiety Disorder 7, which is a 7-question screening tool that identifies whether a complete assessment for anxiety is indicated. There is also the HAM-A, which is the Hamilton Anxiety Rating Scale, and it's widely used and well-validated tool for measuring the severity of a patient's anxiety. Here's an example of the GAD-7. Next, there are several screening tools available for bipolar disorder. There is the Mood Disorder Questionnaire, or the MDQ, and this is a 13-question screening tool associated with bipolar disorder symptoms. A very common screening tool in bipolar disorder is also the Young Mania Rating Scale, which is an 11-item multiple-choice diagnostic questionnaire which psychiatrists use to measure the severity of manic episodes in children and young adults. Here's an example of the Mood Disorder Questionnaire. It starts off by going through some of the questions based on diagnostic criteria for bipolar disorder, and then goes into some more specifics if the individual feels like this is a minor or a serious problem. There are also several screening tools available in psychosis. We have the Revised Behavior and Symptom Identification Scale. It is a 24-item self-report instrument with 6 scales. It looks at psychosis, depression and functioning, interpersonal problems, alcohol or drug use, self-harm, and emotional lability. Another very common screening tool to assess psychosis is the Symptom Checklist 90 Revised. It is a 90-item self-assessment tool that measures psychoticism and paranoid ideations in addition to 7 other symptom scales. We also have the Brief Symptom Inventory, which is a 53-item self-administered scale developed from the Symptom Checklist 90 Revised. This has good psychometric properties and is an acceptable brief alternative to the former. There are also several screening tools available for family and caregivers to assess how an individual may be doing. We have the Family Environment Scale, which is a true-false questionnaire measuring family cohesion, conflict, and expressiveness. There's the Family Attitude Scale, which is a 30-item measure of family stress and expressed anger. The Level of Expressed Emotion Scale is a 60-item measure of expressed emotion. The Patient Rejection Scale measures relatives' hostile and critical attitudes towards their ill family member. We also have the McMaster Family Assessment Device and the Quality of Life Interview, as well as a FACES, which is a measure yielding scores in a number of domains, including family cohesion, adaptability, communication, and satisfaction. There are advantages and disadvantages to the separating out of dementia, cognitive impairment, and mental health problems, given the overlaps in symptoms and the marked similarities between the experiences of people living with dementia and people living with mental health problems. Dementia and mental health problems occur in all populations, but the prevalence and impacts of these conditions vary due to differential access to information and support. Next, I would like to focus on dementia and serious mental illness. Dementia and mental health problems are not mutually exclusive. There are people living with existing mental health problems who develop dementia, and people living with dementia who develop mental health problems. Furthermore, certain dementias may present with features of serious mental illness. Serious mental illness may have an increased rate of cognitive impairment. Also, as one develops dementia, they may not have the control that they once did over previous symptoms. So you may see an emergence of symptoms that were pre-existing, but they have better control over it due to having all of their faculties or being cognitively intact. So this is an important point to note. Serious mental illness may be a risk factor for dementia in late life. For example, depression, bipolar disorder, but likely to happen via shared comorbidity, such as with vascular disease, smoking, diabetes, substance abuse. Chronic serious mental illness, again, such as schizophrenia or bipolar disorder, have high rates of mild cognitive impairment. One study found that 60% of patients over the age of 55 attending a community mental health center were cognitively impaired. Next, we will talk about dementia and depression. The relationship between these two is complicated because of some of the expressions of dementia and depression overlap. The distinction between a mild neurocognitive disorder and major depressive disorder, which can co-occur with a neurocognitive disorder, can also be challenging. Specific patterns of cognitive deficits may be helpful. For example, consistent memory and executive function deficits are typical of Alzheimer's disease, whereas nonspecific or more variable performance is seen in major depression. Alternatively, treatment of the depressive disorder with repeated observation over time may be required to make the diagnosis. Depression is common early in the course, including at the mild neurocognitive disorder level of dementia due to Alzheimer's disease and Parkinson's disease. Apathy is common in mild and mild major neurocognitive disorder. It is observed particularly in neurocognitive disorder due to Alzheimer's disease and may be a prominent feature of dementia due to frontotemporal lobar degeneration. Apathy is typically characterized by diminished motivation and reduced goal-directed behavior, accompanied by a decreased emotional responsiveness. Symptoms of apathy may manifest early in the course of dementias when a loss of motivation to pursue daily activities or hobbies can be observed. Individuals with dementia can present with a wide variety of behavior symptoms that are the focus of treatment. Sleep disturbance, for example, a very common symptom that can create a need for clinical attention and can include symptoms of insomnia, hypersomnia, and circadian rhythm disturbances. We also commonly see sleep disturbances in major depressive disorder. Depression in older people can often go undiagnosed despite the prevalence of risk factors, including bereavement, loneliness, and deteriorating physical health. Oftentimes, we tend to see somatic complaints in older folks with depression. On occasion, someone experiencing depression may be misdiagnosed as having dementia. Individuals dealing with both will be struggling with two sets of difficulties and may be more confused and have greater memory loss. That double experience may also result in more extreme behavior and/or aggressive reactions. This can compound isolation, disempowerment, as well as cognitive decline. Next, I would like to highlight some of the specific differences between dementia and depression. According to the American Medical Association, with depression, the onset takes weeks to months. Mood is low or apathetic. The illness often responds to treatment. The individual is concerned with their memory loss, and the individual may neglect self-care. According to the American Medical Association, with dementia, onset can take months to years. The mood will fluctuate. The course of the disease is chronic and deteriorates over time. The individual may hide their memory loss or be unaware of it, and self-care progressively worsens. Here's a slide with a chart outlining some differences between the depression and dementia. Again, how quickly it happens, difficulty with concentrating in depression versus difficulty with short-term memory in dementia. And in depression, they'll often worry about that memory impairment, whereas in dementia, they may not notice or even care. Next, I'd like to briefly touch on dementia and anxiety. Anxiety is often more common in individuals with dementia than those without. Defining anxiety in people living with dementia is complicated due to the overlap in symptoms of anxiety, depression, and dementia. Anxiety may be higher in vascular dementia than in Alzheimer's disease, and it may decrease as the severity of that dementia worsens. Next, let's look at dementia and bipolar disorder. It can be difficult to identify bipolar disorder in people living with dementia. The two conditions demonstrate similarities with respect to their clinical expression, such as with agitation, psychosis, mood and cognitive symptoms, and structural brain neuroimaging. However, there are important differences with cognitive symptoms prevailing in dementia and mood symptoms in bipolar disorder, a lack of brain structural abnormalities in bipolar that are seen in dementia, and both presenting different abnormalities in functional brain neuroimaging. Individuals with bipolar I disorder perform more poorly than healthy individuals on cognitive tests. Cognitive impairments may contribute to vocational and interpersonal difficulties and persist through the lifespan, even during euthymic periods. Acute mania in people with dementia may resemble delirium or a worsening of dementia. In a person with a history of bipolar disorder who is not on a mood stabilizer, once medical problems are excluded, this should become the first consideration, especially if the patient is agitated, overactive, not sleeping, or is having rapid speech. Treatment of the acute mania usually involves the use of an atypical antipsychotic plus minus a mood stabilizer, and mood stabilizers should probably be continued as long as possible to prevent relapse. Folks with a long-standing bipolar disorder exhibit persistent cognitive impairment, and in old age, the severity can reach the level of dementia. Case studies suggest it might be different compared to other established types of dementia, but the main differential diagnosis here would be frontotemporal dementia. Most have features of frontal lobe syndrome not explained by other organic factors. Mood lability and cyclothymia, refractory to antidepressant therapy, and do better with mood stabilizers. There is also a high rate of extrapyramidal signs Elation may occur more commonly in frontotemporal lobar degeneration. Mood symptoms are increasingly recognized to be a significant feature in the earliest stages of mild dementias, such that clinical recognition and intervention may be important. Also, visual hallucinations may be more common in dementias than in depressive, bipolar, or psychotic disorders. About 90% of the cases of bipolar disorder have a reported onset prior to the age of 50. Which brings me to my next point. Elderly people living with bipolar disorder are heterogeneous and generally consist of at least two types. Those experiencing a late life manic episode and whose bipolar illness began in young adult life, and patients without any manic symptoms or episodes before late life, but may have only had a history of depression. Late onset bipolar disorder may be caused by dementia or may be the preceding presentation of a dementia onset. And again, we want to keep in mind that frontotemporal dementia as one of our differentials. Next, let's take a look at dementia and schizophrenia. Psychotic features are common in many neurocognitive disorders, particularly at the mild to moderate stage of major neurocognitive disorders due to Alzheimer's disease, Lewy body disease, and frontotemporal lobar degeneration. Paranoia and other delusions are common features, and often a persecutory theme may be seen, such as a family member, stealing, things of this nature. In contrast to psychotic disorders with onset in earlier life, such as schizophrenia, disorganized speech and disorganized behavior are not typically characteristic of psychosis in dementia. There is a growing body of evidence showing that people with schizophrenia are at an increased risk of developing dementia. The diagnosis and management of dementia and schizophrenia is challenging. Cognitive impairment and delirium are common features of schizophrenia, present in more than 80% of older people with schizophrenia. Because of this, some have argued that it may not always warrant an additional diagnosis of dementia. However, studies have shown that dementia is a real entity in people with schizophrenia. Cognitive deficits in schizophrenia are common and are strongly linked to vocational and functional impairments. These deficits can include decrements in declarative memory, working memory, language function, and other executive functions, as well as slower processing speed. Abnormalities in sensory processing and inhibitory capacity, as well as reductions in attention, are also found. Some individuals with schizophrenia show social cognition deficits, including deficits in the ability to infer the intentions of other people, and may attend to and then interpret irrelevant events or stimuli as meaningful, perhaps leading to the generation of explanatory delusions. These impairments frequently persist during symptomatic remission. There is very limited evidence to inform decision-making when patients with schizophrenia develop dementia. Antipsychotic drugs, including the older traditional antipsychotics, such as the first-generation psychotics, haloperidol, chlorpromazine, and the newer atypical antipsychotics, for example, risperidone, olanzapine, have been developed specifically to treat the delusions, hallucinations, and thought disorder of schizophrenia, rather than the behavior. They are dopamine-blocking drugs. Dopaminergic abnormalities often drive the psychotic features of schizophrenia. This is not as often the case in dementia. Furthermore, we must keep in mind the black box warning found on labels of all antipsychotics, which reads, "Elderly patients with dementia-related psychosis and treated with antipsychotics have an increased risk of death." Early onset schizophrenia often requires higher doses of medication for therapeutic efficacy than late onset psychosis, and this is irrespective of if there's a dementia process present. As patients with early onset schizophrenia get older, there is often a lessening of the psychotic features. Relatively few have severe psychosis, and some no longer require medications. Depot antipsychotic drugs are best not used in comorbid schizophrenia and dementia due to safety. It is important to not assume behavioral changes due to schizophrenia. Follow the first principles of assessing any behavioral and psychological symptom of dementia and focus on ruling out medical causes for this change, as well as psychological interventions first. Unless the psychosis is bizarre, places the individual or others in harm's way, or resembles the psychosis that the person had when they were unwell with schizophrenia in the past. If antipsychotic drugs are needed to control a schizophrenic psychosis in a person with dementia, they are likely to need continuation for longer than for behavioral and psychological symptoms of dementia, and may require much higher doses than usually used in behavior and psychological symptoms of dementia. I want to broaden this a little bit to talk about dementia and psychosis in general. Psychosis is common in older people, with about 20% of people over the age of 65 developing psychotic symptoms by the age of 85. Often, but not always, psychosis develops in people living with dementia as a feature of the progression of the disorder and can be expressed through delusions, aggression, hallucinations, apathy, and/or sleep disturbance. For example, the prevalence of psychotic symptoms in patients with Alzheimer's disease is over 40%. These behaviors can be particularly distressing for both the individual and their caregivers and may result in a breakdown in family structures when family members feel unable to provide the necessary support. People from African American or Black ethnicity groups have been found to have a higher rate of psychosis. Psychosis is also associated with more rapid cognitive decline. Next, I would like to focus on different types of dementias that may present with psychiatric features. First, let's focus on Alzheimer's dementia. This occurs when biochemical problems inside the brain cells form abnormal proteins called amyloid plaques and neurofibrillary tangles. Alzheimer's is the most common cause of dementia and accounts for more than 65% of dementias in the elderly. It is twice as common in women because they have a longer life expectancy. Depression is commonly seen early in the course, including at the mild neurocognitive disorder level of dementia due to Alzheimer's disease. And we looked at that in a little bit of detail when we talked about dementia and depression. Apathy is common in mild and mild major neurocognitive disorder and is observed particularly in dementia due to Alzheimer's disease. Next, let's talk about frontotemporal dementia. We mentioned this a little bit earlier in the context of bipolar disorder. Frontotemporal dementia, often abbreviated FTD, and also formerly known as Pick's disease, has features that overlap with those of major depression, mania, obsessive compulsive disorder, and schizophrenia. It is a hereditary disorder that affects the frontal and temporal lobes of the brain. It brings about marked changes in personality, and this is one of the highlighted features. Behaviors often become disinhibited and repetitive. It may affect the ability to produce and comprehend language. The age of onset is typically younger, between the ages of 55 to 65 years old. Frontotemporal accounts for about 10% of dementias. I want to focus a little bit on this chart. And this is nice because it can show the symptoms that are commonly shared with frontotemporal dementia and major depressive disorder. And then also the same can be said for mania, obsessive compulsive disorder, schizophrenia. And then on the other side of the chart, it shows symptoms that are rarely shared with frontotemporal dementia and major cognitive disorder. So I just want to go through a few examples here. So symptoms that you might see in a major depressive disorder and an FTD would be anhedonia, or the lack of interest and pleasure in doing things, psychomotor agitation or retardation, decreased motivation and energy, and a decreased concentration and focus. Symptoms commonly shared in an FTD and mania would be logorrhea or excessive talkativeness, flight of ideas, distractibility, increase in goal-directed activities and impulsive behaviors. Symptoms commonly shared with a frontotemporal dementia and obsessive compulsive disorder will be the compulsions. So rarely you would see the obsessions. That's not a symptom that's shared between the two. And then symptoms commonly shared between FTD and schizophrenia would be the disorganized speech and behavior, affective flattening, and avolition. You might not necessarily see an overlap in complex delusions or auditory hallucinations. And there's a note here, and that is unless there is a mutation in the following gene, C90RF72. In frontotemporal dementia features progressive disintegration of temperament and conduct, apathy, indifference, impulsive behaviors, compulsions, hyperactivity, disinhibition, overeating, and socially inappropriate behaviors are typical features. If there is a new onset of a psychiatric disorder in middle age or older patients, while that may certainly occur, that should prompt consideration of If there is a new onset of a psychiatric disorder in middle age or in older patients, while that certainly does occur, that should prompt consideration of a neurodegenerative disorder. So should any family history of dementia, Parkinsonism, or motor neuron disease. Studies found that abnormal gait, frontal release signs, functional decline, unusual calmness, and violation of personal boundaries distinguished frontotemporal dementia from psychiatric disorders. So this is an important point to note as well. Next, I would like to turn the focus to Lewy body dementia. This is also known as dementia with Lewy bodies, or DLB. Dementia with Lewy bodies cognitive deterioration is due to protein deposits called Lewy bodies, developing in nerve cells in the brain regions involved in thinking, memory, and movement. Signs and symptoms may include sleep disturbances, such as REM sleep behavior disorder, psychosis, including hallucinations and delusions, slowed movements, rigidity and tremors, gait imbalance, visual spatial problems, and short-term memory may be preserved. Lewy body is the third most common dementia, and the age of onset is typically on or after 60 years of age. Considerations to make with Lewy body dementia include worsening of extrapyramidal symptoms or lack of improvement of psychiatric symptoms with the use of antipsychotics. This is commonly seen. Next, let's look at vascular dementia. This is also known as multi-infarct dementia. It is a cognitive deterioration related to cerebrovascular disease. Anxiety may be higher in vascular dementia than in Alzheimer's, and it decreases in the severe stage of dementia. Depression may also be a presenting symptom in vascular dementia. Risk factors include strokes, heart disease, high blood pressure, diabetes, high cholesterol, and smoking. Both vascular dementia and Alzheimer's dementia can occur together. This can represent a mixed dementia. The decline in vascular dementia may be gradual. It can have a patchy or fluctuating course, and this can be frustrating for caregivers and for treatment providers. Vascular issues are the second most common cause of dementia among the elderly, especially in men after the age of 70 years old. And again, too, if some of these risk factors are present. Next, I would like to briefly look at intellectual disability, Down syndrome, and dementia. The assessment of dementia in the context of an intellectual disability is a complex one because of the many explanations that can account for cognitive deficits and decline. These include pre-existing intellectual difficulties, physical illnesses, and co-occurring mental health issues that can masquerade as dementia. As a result, dementia may progress before the initial diagnosis is made. I also want to explore the correlation of Down syndrome and dementia. Longevity has increased for all individuals, including those diagnosed with an intellectual disability. As greater numbers of people are surviving into older age, there is a higher risk of developing dementia. And as we saw earlier, increased age is one of the top risk factors for developing dementia. This is uniquely true for those diagnosed with certain disorders, such as Down syndrome. These individuals have a 4 times higher risk of developing Alzheimer's disease due to genetic factors. National researchers offer the following estimates about Down syndrome and dementia. About 22% for adults 40 to 60 years of age, and 56% for adults 60 years of age and older. I would now like to revisit the case with the information that we've learned up until this point. A successful 56-year-old grocery store owner began to have trouble finding names for people and objects, such as types of produce. He continued to place newspaper ads for his grocery store deals, but had trouble filling out paper orders for food shipments and was making frequent spelling errors. Shockingly, he was caught stealing a wine bottle opener from the liquor section. Not long after, he began to search his backyard, spending many hours looking for pine cones. While at home, he began to play solitaire on his computer compulsively for 6 hours every day. He developed a new interest in tennis, and his game steadily improved. He stopped working as a grocery store owner but obtained a grocery delivery job and learned and remembered a complex route for delivering packages. There was no family history of dementia. So let's look at a couple potential case questions for this case. What type of neurocognitive disorder do you think this patient might have? What are some features of this neurocognitive disorder? And what type of psychiatric symptoms is he displaying? In terms of the type of neurocognitive disorder, we might want to consider a frontotemporal dementia. Why would this be the case? What are some features of frontotemporal dementia in this particular example? There are the compulsions, playing solitaire for hours on end, searching for pine cones in his backyard. Personality changes, picking up tennis, stealing. The disinhibited and repetitive behaviors. Again, stealing the wine bottle opener, searching for pine cones and playing solitaire. And a functional decline. He started to have trouble filling out work orders, making spelling errors. Also, a younger age of onset compared to other dementias. The patient in this case is 56 years old. And what type of psychiatric symptoms is he displaying? Again, if you recall the chart that we saw linking the frontotemporal dementia to symptoms in major depressive disorder, bipolar disorder, obsessive compulsive disorder, etc., we can point out now that we're seeing those compulsions and then also personality changes, disinhibited and repetitive behaviors. In conclusion, we have taken a look at some specifics regarding the prevalence, risk factors, screening tests, and types of dementias or neurocognitive disorders. Similarly, we have looked at statistics, definitions, and screening tests of serious mental illnesses, including bipolar disorder and schizophrenia. We have also taken a detailed look into dementia in the context of serious mental illness and explored how certain neurocognitive disorders may have psychiatric features or presentations, for example, anxiety, symptoms of depression, psychosis, etc. A brief look was also taken at dementia in intellectual disability and in Down syndrome. Finally, a case example was explored. Thank you very much for tuning in today. Goodbye.